you. So I have a fun topic, which is very nice because I was able to assign it to myself. And I called it Emerging Therapies for Type 2 Diabetes, but I will be honest, it's a bait and switch. It really should be called Underutilized Therapies for Type 2 Diabetes, or maybe therapies that you maybe didn't know about for Type 2 diabetes. And I should disclose that I have consulted for Sanofi, and if you have a consulting job for me, if you know, I'll be here all afternoon. And if we do have more discussions and more questions for Dr. Smith, we can maybe have them outside of the lecture hall. So as we are embarking on this topic, first of all, we would want to know, what are we treating for? What are we treating toward? And that has changed considerably. I remember when I was training, it used to be the lower you can get your patient's blood sugar, the better. And many of my patients still have that attitude, still have that opinion. And they're very disappointed when I tell them, well, you know, maybe not. So yes, if you have a young patient who has just been diagnosed with diabetes, will have many years to live with this condition, who has no complications yet, then you should aim for an A1C target that's closer to 6. But if you have the proverbial little old lady who is at risk for a fall from hypoglycemia, and who is not going to get that much out of tight glycemic control, it is absolutely okay to aim for a somewhat higher hemoglobin A1C, closer to 8%. And many of our patients don't fully understand this shift in treatment paradigm. And we really have drifted away from the lower is always better paradigm. And that's important to know because it influences your choice of agents and how aggressively you treat. And it's important to know because of the algorithms that we use to treat. There are two algorithms that are being bandied about a lot. One is from 2012, the revised ADA algorithm. You start off with metformin, and then you add to that. And then if you don't get to your target with 2 agents, then you go to a 3rd agent. And if you don't get to target with that, well, then you do insulin. There are newer guidelines out from the American Association of Clinical Endocrinologists, or ACE, and I have to tell you that it took me a while to fully comprehend them. And essentially, what you learn there is that you can use many agents as your initial treatment. But if a patient comes to you with an A1C greater than 7.5, they want you to start with 2 agents right off the bat. And if that doesn't work, then 3 agents. And if an A1C is greater than 9, you should go to insulin. So after having thought about this algorithm and trying to figure this out, I went back to this. Because I can remember this. Now, you know, individual paths will vary, and not every patient will necessarily tolerate metformin or will be a good candidate because of comorbidities, but this I can remember. Well, but why is it that dual therapy is so recommended? And that's because if you start off on monotherapy, many patients with type 2 diabetes will, over time, require a 2nd agent. And depending on what you start them on, that time will come sooner or later. It will come much sooner with a sulfonylurea, for instance, like Glyburide. It will come somewhat later with metformin, but even patients on metformin may, over time, require an additional agent, a 2nd agent, or a 3rd agent. And this is from a large trial called ADOPT, published in New England Journal of Medicine. Now, as you are being presented with, you know, evidence-based medicine and with studies, you always, you know, people will tell you, oh, this agent lowered A1C this and this much. Well, you have to know what population was it studied in, because most of these trials take patients who have had diabetes for a fairly short time and who have relatively high A1Cs, and then the higher you start off, the better your success is going to be. So you always have to put things into context. You also have to remember that most agents, other than insulin, require some degree of beta cell activity of your patient. So that's something to keep in mind as patients are progressing on the path to type 2 diabetes and are losing beta cell function. One class of agents that I want to highlight that's been around for a long time, so it's not so emerging, but it's definitely underutilized, is alpha-glucosidase inhibitors. There's a generic agent available called Precose. It's been around for quite a while, and you get an A1C reduction of 0.7% with it. It's tier 1 for most insurance companies. And what it does is it prevents breakdown of disaccharides in the gut, in the brush border of the gut. And so essentially, those disaccharides go through you. And if you don't use them, or if your patients don't use them, then somebody else will. That somebody else are the gut flora. And the side effect is, the scientific term is farting. Sadly, that is a very common side effect, and so these agents, even though they're very safe, and not much systemically absorbed, but they're very safe agents, but they're far underutilized because a lot of physicians don't want to prescribe something that makes you fart. But it's you know, you prescribe it before meals. It's a little bit of an anti-abuse effect with carbs. You know, if the patient doesn't eat any carbs or eats few carbs, then they will not have any side effects. And I have many patients on this, and I feel that this is a great option, especially for postprandial glycemic control. And the other thing is that these agents actually have cardiovascular safety data attached to them. A little bit about incretins, not cretins. Incretins, the incretin effect describes the considerably larger insulin response to oral glucose as opposed to IV glucose. And the incretin effect is kind of the first thing to go in early type 2 diabetes, which is quite interesting. Incretins, mostly GLP-1 and GIP, are produced in the L cells in the gut, and what they do is they prime they prime the beta cells to put out more insulin. But in addition to increased insulin secretion, they also have an effect that decreases beta cell apoptosis, that slows down gastric emptying. So certainly not something you want to use in patients with gastroparesis. But if you have slower gastric emptying, you will feel fuller. And that is often beneficial if you don't want to eat as many cookies as we just did. And they also decrease appetite, among other things. So quite useful. Now, when GLP-1 was initially found, it was very exciting. Because people immediately realized that this could have a pharmacologic potential. The only problem is that GLP-1 gets cleaved quite rapidly, within minutes, by DPP-4 in the bloodstream. And so native GLP-1, your own GLP-1, does not last very long. So it took a very smart guy named John Eng, who was an attending here at the Bronx VA hospital, which is, of course, affiliated with the Mount Sinai School of Medicine, who found in the saliva of the Gila monster Exenatide 4 and built on that Exenatide, which is a medication you can prescribe to your patients. So you can say, this is lizard spit, this is great. Not really, but it's derived from it. So this was the first approved drug in this class as a GLP-1 agonist about 8 years ago. It's a BID drug. And over time, we got newer agents such as liraglutide, which is once a day, and then exenatide weekly. Exenatide ER, which is once a week. So over time, companies have developed longer-acting and longer-acting agents. And why is this relevant? Well, not just for compliance for patients, but also because these drugs act very differently. They do different things. What you see here with Exenatide is that you get much more of a postprandial effect. What you see here with liraglutide, which is once a day, or Exenatide once a week, you see more of a fasting glucose effect. So they act differently. It's very interesting. Now, over time, what you see is that A1C is reduced with these agents. This is Exenatide twice a day, and you see an A1C reduction of about 1%. But what you also see is because of the decreased appetite and the slower gastric emptying, you see weight loss, which is very nice. And that's even though GLP-1 receptor agonists are injectable agents, and most patients are not so excited about injecting something. This is something that I tell my patients, I can't promise you, but there's a good chance that you'll be able to lose some weight. And this is a Gila monster. This shows you that liraglutide, which is longer acting, it's once a day, has a very nice effect on fasting blood sugar. And again, the longer acting agents work more on the fasting sugar, the shorter acting agents such as Exenatide more on the postprandial. The other thing that you notice is that the longer acting agents work better in terms of lowering A1C. So this is Exenatide combined with liraglutide, and this is Exenatide twice a day versus Exenatide once a week. And so again, you see much better, or you see significantly better A1C reduction. Finally, you can make a case that these agents could be prescribed in some cases instead of insulin. The way I use that often is in patients who are not capable of injecting once a day insulin by themselves, and then I do Exenatide once a week by a family member, for instance. But these agents can be very effective, as you can see here, in comparison to insulin. And then finally, and I think this is an underutilized trick, these agents go really nicely with basal insulin as an addition. We heard from Dr. Weinstein earlier that we often see patients where basal insulin gets increased more and more and more and more and more and more without thinking about what happens after meals. Well, if you combine basal insulin and then give on top of that Exenatide twice a day, you kill two birds with one stone. You can control postprandial blood sugar with less risk of hypoglycemia, and at the same time you can neutralize or even reverse the weight gain that you often see with insulin. So that's something that I like to do quite a bit, combine these two classes, basal insulin and a GLP-1 receptor agonist. And the reason why I'm spending so much time on a class of agents that's 8 years old is because endocrinologists prescribe these all the time. Primary care doctors, not so much. And so I want to get the word out there that this class of agents can actually be useful in the right setting. Something that primary care physicians have gotten very good at prescribing is DPP-4 inhibitors. DPP-4 is the enzyme that cleaves GLP-1 and GIP. And so what this means is that patients have more of their endogenous incretins. These agents come in pill form, so they're more practical, more easy to take. Great in patients who have mild hyperglycemia. I use these agents frequently in elderly patients who are at risk for hypoglycemia because that is not a side effect you would commonly see. And certain agents can be used in patients who have renal insufficiency without dose adjustment. Sitagliptin, which is the most commonly prescribed agent in this class, can be prescribed to patients with renal insufficiency. You just have to adjust the dose appropriately. What I do like about the agent is that it does not interfere with the cytochrome P450 system, which for somebody here at Mount Sinai, where we see a lot of transplant patients and a lot of patients who are on a gazillion drugs for many other conditions, I find that very useful. And finally, they're weight neutral and work from day one. But what I do want to point out is that these agents, even though they're related, are not the same. And probably that's because you get more GLP-1 activity with GLP-1 receptor agonists. So you get more side effects, such as nausea, vomiting, and Dr. Levy is going to be talking about that. But you also get more effect. And that's why they are not the same. We just heard recently from Dr. Smith during the panel that maybe a good alternative to a statin drug could be Colesevelam, which is a bile acid binder, and it's supposed to be a cholesterol drug. So why does it appear in a diabetes talk? Turns out that it blocks glucose absorption, and it works fairly reasonably well. You get an A1C reduction of about 0.5%. You don't get hypoglycemia, and you can kill two birds with one stone. You get LDL reduction, and you can reduce A1C a little bit. Patients are not so happy about the constipation that it usually brings with it, and you can see an increase in triglycerides. The real barrier that I encounter when I prescribe it is that you either have to prescribe it as 3 pills twice a day, or as a delicious powder that goes into a patient's drink and is very similar to how some of us take our fiber in the morning. And most of my patients still opt for the pills over the drink once a day. Something to watch out for with this agent is because it reduces absorption, you have to watch out for malabsorption of fat-soluble vitamins. And what you can see is that it's a great add-on therapy to other agents. So if you have patients on several oral agents and you want a little bit of an A1C reduction with a little bit of an LDL reduction, this could be a good choice, and it's very underutilized. Another treatment that you may not have heard about is bromocriptine. Bromocriptine is used by endocrinologists to treat prolactinoma. It's a dopamine agonist, and probably dopamine works by resetting the biological clock. And something about doing that improves postprandial blood sugar later in the course of the day. So if you take rapid-acting bromocriptine within, it's especially formulated, within an hour or two of waking up, over the day, your postprandial blood sugars will be better. A1C reduction is about 0.5%. The most common side effect that we see is nausea. Not so much vomiting, just nausea and feeling a little off. You start off with 1 pill, and you can updose until 6 pills every morning. And what's remarkable about this drug, in contrast to other diabetes agents, this drug actually has cardiovascular safety data, and it's very beneficial for this drug. What you can see is a reduction, an actual reduction in cardiovascular events in a randomized clinical trial. So that is something to keep in mind if you want to aim for an A1C reduction of about 0.5%. And then finally, there's a brand new class of agents called SGLT2 inhibitors, and the very first agent within this class has been approved by the FDA. You'll see more of these over time, and so this is very current. SGLT2 is a symporter and mediates 90% of glucose reabsorption from the ultrafiltrate back into the bloodstream. So if we didn't have SGLT2, all of our glucose would be going out through the kidney. And here you can see the sodium glucose symporter, SGLT2, and it's an active symporter against the gradient. and it brings glucose back into the bloodstream. So if you block that, well, then you don't reabsorb your glucose, and it stays in the urine. And the agent that's available at this point, there'll be more eventually, but the agent that's available at this point is Canagliflozin. And you see A1C reduction of about 0.7 to 1% with this agent. What's nice is you can use it as an initial agent, but it's great as an add-on therapy. In fact, this trial here compared metformin and sulfonylurea plus, as a third agent, either canagliflozin or sitagliptin. And of course, trials are created in a way usually that will show off the beneficial sides of an agent. So you have to take everything with a grain of salt. But still, canagliflozin showed greater A1C reduction as a third agent than sitagliptin. What you also see is you can see some nice weight loss. Not as much as with GLP-1 receptor agonists, but you can expect 2, 3, 4 pounds. And actually, I have one patient who just emailed me earlier this week who complained of 8 pounds weight loss, and he wasn't that big to begin with, so that was a little bit overshooting. I have here, for your benefit, kind of a master list of all this is not just oral medications because, this is oral medications, sorry. Of all oral medications for type 2 diabetes, so that you can refer to it. It's in your handout. And I don't expect you to memorize this right now. But I just wanted you to have that slide so that you can always look back to it. So in conclusion, think of acarbose not as and that's the generic name. I used the brand name inadvertently early in my presentation. I apologize. Think of acarbose not as an emerging treatment, but as something that has been around for many, many years and is just underutilized and is a great agent. Think of GLP-1 agonists, the injectables, if you have obese patients with type 2 diabetes. They're very effective. And think of combining these agents with insulin. DPP-4 inhibitors are a great choice if you're looking for a safe option without hypoglycemia. Colesevelam is an option if you want to target LDL with a modest A1C reduction. Bromocriptine is a heart-healthy option that is little known. And finally, SGLT2 inhibitors are great as add-on therapy, but they only work well as long as the patient has good renal function. They really live or die by a patient's renal function. So with that, I thank you for coming, and thank you. And we're ready for the next speaker.